I don't know if you saw the response. Thanks to my colleagues for being here as well too. Appreciate getting up here and look forward to seeing all of you guys and ladies here very soon. Let me just, this is Medical Cannabis Working Group hearing. Let me just introduce my colleagues that are here as well. Beth Beskin, Representative Beth Beskin is here. Representative Michael Caldwell is here. Speaker Pro Tem Jan Jones, thank you for being here. Appreciate your interest in this issue. Representative David Clark and Representative Micah Gravely. I believe Representative Valencia Stovall will be here shortly as well too. So we've got 3 presenters today, and purpose of today is just kind of more information gathering for the committee as well too. This will be the only time we'll meet before we get back in session. Remind everybody to cut off their phones as well too. So. So first up, we've got Donna Moore, who's Executive Director with Vital Records. If you want to come on up, and we'll let you get started. To the members of the committee, the Vital Records is the group and agency that is overseeing the low THC oil registry, and so I thought it might be prudent that we get an update from Ms. Moore of the registry, so we're glad to have you here, and why don't you jump on in. I know we got some issues with the PowerPoint. It's kind of small. We can't really zoom in, but we're going to go ahead and move forward as well, too.
Okay, thank you. Good morning, everyone. My name again is Donna Moore. I'm the Director of Vital Records and the State Registrar for Georgia. The low THC oil registry sits in the Vital Records shop as part of the Department of Public Health. And we have had this program a little over 2 years. And I wanted to give you not only an update on what has happened thus far, but also what's happened since July of this year, 2017, with the change in the legislation and what that's done for the program. I'm really sorry you can't see this slide, but I'm going to do my best to go over the points for you, and I think we can provide this to you after the program today.
That'd be great. We'll get it to all the members of the committee via email. If you
okay.
Get it to me electronically.
So in April of 2015, the original legislation said that the low THC oil program would cover 8 conditions. We worked with the Composite Medical Board to develop the processes for how physicians would get their patients into the program. We also said in the legislation, you said in the legislation, that the physician has to confirm a relationship with their patient. It's not a prescription, and it's a relationship with their patient, and they acknowledge through the registry that they are treating this patient as their own. The legislation in April of 2015 also said that physicians would offer quarterly reports on their patients into the registry. We built an in-house website for registration, for fulfillment of cards, and for physician reporting. We developed a process to what I call ping the CMB database for active physician licenses. If you remember the first time I was here, I told you we had a 17-year-old posing as a physician, and when we pinged the database, we rejected his application. We stood up the registry and processed it in 6 months. And then we were able to issue the first card in July of 2015. We attribute our success for this quick process to the fact that we built it all in-house. Working with CMB, working with DPH, working with our own programmers, we built our program in-house. And if you remember the very first meeting that we had in front of the working group, we had a representative who came and said other states would take 2, 3, 7 years to build their registry. So be proud of what you accomplished here in Georgia through the way you set up the program. In July of 2017, the legislative changes said that the package for low THC oil in Georgia needed to be in a pharmaceutical container, it needed to be labeled, and it needed to note the percentage on the bottle. We also said in the legislation that other states' cards would be honored in Georgia if someone was found with low THC oil on their person. You removed the requirement for 12-month registry or residency, and you changed the quarterly reporting requirement to semi-annually, and you were silent on what semi-annually meant, so we are working with CMB to determine what that means for them. And you expanded the conditions from 8 to 14, plus you added hospice care. So as of January 2017, we had 318 physicians registered. We had a little over 1,300 patients and a little over 1,600 caregivers. Now remember that caregivers can get a card as well as the patient can get a card. And in the middle of the slide, you'll see the card itself. In September, I did an update for you. In September of this year, we had 453 active physicians in the program. We had almost 2,700 patients and a little over 2,700 caregivers. If you look at the conditions over time, if you look at the graph, and I know you can't see this, but the first 8 conditions with the red bars and the blue bars are the original conditions. And then in July, from that legislation, we worked very, very quickly and in a couple of weeks had the additional conditions added. And in September, from the additional conditions, we added 471 patients. Peripheral neuropathy had 270 of those 471. Autism had 109. And then Tourette's, hospice, Alzheimer's, AIDS, and epibulosa had less than 10. So that is the impact of the changes and the additions of the conditions from your legislation. So again, the 2 primary changes were for peripheral neuropathy patients and autism patients.
Ms. Moore, so I want, just for the committee's sake, I mean, we had almost 2,000 people sign up for the registry before the law went into place, the change in the law, and so if my numbers are right, we're looking at adding almost 200 people a month since the additional conditions have gone in, and that's from what I've been seeing, and that's been pretty consistent. Is that right?
That is correct.
Yeah.
That is correct. So since the law changed, we added 471 patients, and you can see that over half of those were those 2 conditions, neuropathy and autism. Yes, sir.
Representative Gray, what number are you? 22? There you go. There you go.
That's the 471 is on top of the 453 from September, correct?
That's physician. That's patients.
That's exactly right.
Yeah.
So I'm just trying to get the total number of patients we have in the program now.
So in the program now, as of the end of September, we have 2,682, and of those, the subset of 471 is a part of that 2,682.
Thank you.
Yep. And that's the end of September. They've been adding about 200 a month, so we're probably close, scaring 3,000 probably at this point. Is that correct?
That
Ms.
is
Moore?
correct.
Yeah.
That's a good projection.
Yep. Okay.
The other thing I want to mention through September 17 is some of the interesting facts about our database is that 55% of patients have seizures or cancer, and this is of the totality of the 2,682. Another 25% have MS, neuropathy, or Crohn's. So if you were to look at the mix of the conditions, that's where the bolus of them are. 80% are seizures, cancer, MS, neuropathy, or Crohn's. And then if you look at the age breakdown, 40% are 50 or older. Another 31% are 25 to 49. So that's 70% as well are adults. That was a little surprising to me because I thought that we would have more children in the mix. So some of the issues that we have had since we started the program, since we took over the operation of the program, we have had repeated requests for physician referrals. And as DPH, we don't feel it's our place to refer patients to physicians. And it's because from the original legislation where we established that patients have to have a relationship with their doctor. Any doctor can enter into the database. Any doctor. It doesn't have to be a specific specialty. So the patient's existing doctor, whom they already have a relationship with, could enter them into the registry. So we didn't feel comfortable referring patients to a doctor. That may be an issue for someone else. The other issue that we've had is reporting compliance. And we have about 75% of the physicians reporting on their patients. Going to semi-annually, I think, is going to help that. But we do have a problem with reporting compliance. And policing. So DPH is not the governor or governance of the reporting physicians, and we are in conversation with CMB to figure that out as well. And then another issue, of course, is data in the registry. Probably about 10% of the time we have to call the physician back because they entered some data wrong on a patient and we can't find that patient. I do want to brag just a minute, and this is in the lower blue box, on the relationship that we've had and the collaboration we've had with the Composite Medical Board. This relationship was and still is a success. Finding a way to ping their database so that it wasn't a manual process was a collaboration with CMB, and they approve physicians into the registry within 24 hours. If that were a manual process, it wouldn't be that quick. Also, access to their leadership and their expertise in working with physicians has helped us to solve a lot of problems in the registry. And then the next slide, when you get this presentation on the left, that is the quarterly reporting form. This is the form that physicians fill out on their patients. And again, we're going to semi-annually reporting. And it will have all of the conditions listed, and the physician will tell us a little bit about that patient. And then on the right is the solicitation that DPH sends out to remind Dr. Smith, Dr. Jones, Dr. Williams, that they have patients in the registry and that they need to submit their reports. And then down at the very bottom is our status through April 15th of this year, which was the last time we did reporting. And at that time we had 1,500, a little over 1,500 patient reports that were required. A little over 1,000 were completed. There were 93 patient cards canceled. And patient reports that were not completed was about 25%. I want to speak on that patient cards canceled during the reporting period. Some of these patient cards, either a patient dropped out from under their physician care or the patients were deceased.
And how many are you seeing, 10 a month?
Through the existence of the program, we've had about 130 patients pass away.
Okay. Yeah. Or not register, or not re-register their card for some reason.
That would be on top of the 130.
Okay. Right. Okay.
We did have, and I think I mentioned this to you last time, we have had people call us and cancel their cards on purpose and ask for a letter confirming that their cards have been purchased because their employers were doing marijuana testing. Okay. And their employers had told them that they would lose their jobs if they tested positive.
Okay.
So I've done a couple of those letters.
Okay. Any questions from the committee for Ms. Moore? Ms. Moore, I'll ask a couple while my colleagues may be thinking. How quickly is the turnaround between time someone is applying for the card or the doctor submitted the registration before they're actually getting the card? What's your turnaround time?
Our current turnaround is about 7 to 10 days because our process is, if everything goes smoothly, the information in the registry is entered correctly, we will contact the patient within the business week, within 5 business days, and then we send their card to one of 18 distribution points inside our boards of health in our network. and then they go in and pick up the card. But it's usually within 2 business weeks, 7 to 10 business days.
Okay. And could you, just for the committee's benefit, your team has done a great job, and I've actually met many of your team, and they shared with me some stories of what they're hearing from patients when they come. Can you kind of share with the committee kind of what is the to the folks that are on the front line, your team interacting with these patients, what are they asking and what are their requests when they're coming forward?
So I'll tell you a couple of stories. We had a physician send one of my team members that works on the low THC registry, sent her lunch for the entire team from a seafood restaurant. And the note just said, "Thank you for what you're doing for my patients." And my team was very touched because these are the individuals on the front lines talking to these patients. We had a young man in his 30s come into one of our distribution points last week. He was going on a cruise, and he was traveling through Georgia. And he lives in Georgia, and he wanted his low THC oil card, and he came to our facility, and he cried like a baby for the opportunity to have this card, and to know my program person shared with him that she had heard stories of appetites coming back, and he was suffering from that. And he was just so pleased and so happy to have this card. He bawled like a baby. And these patients that are carrying these cards, the parents, the patients themselves, are just so touched and so humbled by the fact that they have found something to help them. And you can drink a gallon of this stuff and not get the proverbial high from marijuana. And, they are sometimes a little scared as well. What is this going to do to my body? But the outcome from patients, from the anecdotal stories we've heard, is it brings back appetite. It brings back the quality of life. It brings back the lack of nausea. And I'm sharing the anecdotal stories that we hear. We had a mom come in with her toddler daughter. And for 6 months, she had the card and was giving this daughter low THC oil. And when the child passed away, she contacted us because she had become close to our program folks as well. They were checking up on her and making sure that she had what they needed. It is not outside of the realm of reason for any of my 18 registrars across the state to deliver a card to someone who is homebound. We at DPH, we see ourselves as public servants. And if I can drop off a card to someone at home that cannot get to me or get to one of our offices, that is not unusual for someone in one of our 18 distribution counties to do that. We're not about the politics or the legislation. That's your job. We're about getting those cards to folks who need them. And, we take that very, very seriously. And, my clerks are in my office on a regular basis telling me stories about patients that have been helped because the patients want someone to talk to, and they'll call us back and share their stories. Our hands are a little tied as to what we can do with that information, but, it makes my employees feel good to know that they've made a difference and that they've helped patients get these cards.
Well, you guys have done a great job administering this program, and so kudos to you and your team for doing that. Just to the members of the committee, the little conversation I've had with Ms. Moore and her team, the questions that they keep getting hit with when they get their card is, okay, what do I do now? I have the card now, but what do I do now? Where do I get it? Where do I access this low THC oil product? And so that continues to be the challenge for all of our citizens. We have this law in place, but we don't provide an access point for them to get something that's safe and lab tested and consistent. And so I know your team has at least communicated to me that's been a real question that they have. The other thing that has come up has been access for the product in schools. We have many of our patients that are registered who are taking the low THC oil 2 or 3 times a day, and they're students. And we've had a couple of instances in particular where the students have contacted me and said, "Hey, I've gone to my administrator, and they won't let me have the product on campus." In fact, one particular case in Macon or in Houston County, just south of where I am, where they said, "Well, you're gonna have to leave school, go off campus grounds to access the product." And so we've got a real challenge on that we're going to need to address at some point of how do we deal with that. I've reached out to the superintendent and have not gotten a response from the state superintendent as well too. And the other issues that Ms. Moore brought up was the employer issue. We still have employers that are saying, and we were silent on the law when we wrote it on purpose. But it is an issue that we're probably going to have to address at some point. Is what is the right of the employee in a workplace environment? So those are challenges that I think we're going to continue to face. But okay, any questions, Ms. Moore? Ms. Moore, thank you. We appreciate you being here. Thank you for your good work and keep it up.
Thank you very much. It was a pleasure to be here this morning. Thank you.
Thank you. Okay, you want to fix the IT projection for us? Next, we got Dr. David Bradford. Once you're coming up, Dr. Bradford, and maybe we can make sure we got everything working. To the members of the committee, Dr. Bradford, while he's getting set up, is no stranger to this legislature. He came and spoke last year, gave a really compelling presentation, and has done some peer-reviewed research on medical cannabis laws and the impact that they have on opioid usage or abuse or deaths. As well as the financial impact that it has. And so I've invited him back. He and his daughter have done these 2 research papers that have both been published, and I think they've done a follow-up, and so that's what we're looking forward to hearing from him today. He can tell you more about himself, but he is the chair of public policy at UGA, very well-respected professor there at UGA, and so it's going to be a real treat for us to have him testify for us today. And as soon as you're ready and up and running, we'll let you tee it up.
All right. All right.
And I'll let you introduce yourself better than I probably did. You can tell the committee more of your position there at UGA as well too.
Well, while we're waiting for this, can I also ask Representative Peak, I'm an academic, so I need strict limits on how long you let me talk. What was
All right. Well, let's see. It is 11. It's 10:30 now, so about 11 o'clock. If you're still talking, I may cut you off.
Okay.
But
all right.
But because I want to leave time for some questions and answers as well from the committee and to the members of the committee. If you have questions during this presentation, we'll probably let you go ahead and ask them if that's okay.
For sure.
While they're fresh on people's minds. And while we're glad to have Representative Katie Dempsey here, who came in. Glad to have you here, as well as Representative Valencia Stovall. Glad to have, who's vice chair of this committee actually as well too. So glad to have y'all here as well. And I think Representative Karen Mathiak was here. She may have left, but
Very good.
oh, there you are. Yeah, glad to have you here as well too. So, yep. Okay, Dr. Bradford, why don't you tell us a little bit about who you are? Make sure that your creds. Make sure this committee knows you're as impressive as I've made you out to be. So, and then we'll let you.
Well, I don't know about that, but I'll tell you a bit about who I am anyway.
Okay.
My name is David Bradford. I am a professor, the George D. Busby Professor in Public Policy at the University of Georgia. I am an economist by training and work in the Department of Public Administration and Policy over in the School of Public and International Affairs. Been here at the University of Georgia for about 8 or 9 years and It's quite an honor to work at this fine institution. I'm going to talk to you today a bit about some of the work that I've done in collaboration with several co-authors at the University of Georgia. One of them, whose name is on the sheet here, you'll notice it's the same last name as me. She's my daughter. It's been a lot of fun to do work with my daughter on these issues. I also want to acknowledge the work of Dr. Amanda Abraham, also in my department at University of Georgia, and Dr. Grace Bagwell Adams in the School of Public Health there. So all four of us have been doing a number of projects related to medical cannabis and as the policies have been implemented across the United States, to ask how they drive prescription drug use, particularly opioids, and how it also is associated with opioid mortality, and whether or not cannabis can be a valuable tool in the arsenal of trying to sort of combat opiate mortality. I know that you guys have one set of objectives, which is to try to make sure that the healthcare needs of patients that might benefit from, in particular, this low THC, high CBD oil, how they can get access to their cannabis products. But there are broader issues you might want to consider as we go along, and so that's sort of the topic that I'll cover today.
Okay.
I also want to do a couple of things. I want to try to accomplish a couple of goals with my comments to you. And again, as an economist, we typically would not have, economists would not have let me go this long without interrupting me. So do feel free to ask any questions anytime you want. But I wanted to talk a little bit about sort of the policy context nationally and talk a bit about some of the clinical developments just this year in terms of what the medical community's position and attitude is with respect to the use of cannabis medically, and what that might imply for the Controlled Substances Act, and then talk to you a bit about what we have been learning at University of Georgia and other research teams across the country about how cannabis can be effective and what the implications are when it's made available to patients for medical purposes. Now, I do want to actually make one comment, because I may forget to make it later. The research that exists nationally and coming out of our team in Georgia is focused primarily on states that have provided access to botanical cannabis, that is whole plant cannabis. There haven't been enough states. The trend that Georgia adopted with the low THC oil is a relatively recent phenomenon. We haven't had enough time to collect the data to study that very well. So I'm happy to think through with your questions about what our results might mean for that low THC extract. But you'll see that the results for whole plant cannabis are actually quite remarkable. All right, so some of the recent developments. Let me just very, very quickly, because I'm sure you guys are familiar with this, but this movement towards allowing patients to have access to cannabis as a therapeutic agent really began in the 1990s, when even though there was difficulty with doing clinical studies on cannabis because it's Schedule I, because there's something called the NIDA rule that requires any clinical trial, whether it's funded by the government or not, to purchase cannabis from the NIDA-approved vendor. There is only one NIDA-approved vendor in the United States, and I will say, as a graduate of Mississippi State University, I'm very pleased to sarcastically point out that the Ole Miss is the only place you can go to get this product, and they probably do a pretty bad job of it, but because of course it's Ole Miss. But in any event, despite the hurdles put in place of researchers doing work in this area, a significant body of research had developed even by the 1990s to suggest that cannabis could be a useful alternative. One of the barriers, though, is the fact that the Controlled Substances Act of 1970 makes cannabis a Schedule I drug. And Schedule I drugs, by the language of the law of the 1970 Controlled Substances Act, Schedule I drugs are defined as drugs that have no currently accepted medical use and have a high potential for abuse. And heroin, LSD, cannabis, ecstasy, peyote, there's a variety of drugs on Schedule I. One of the key controlling language here for our purposes moving forward now is this notion that there's no currently accepted medical use. And as of January of this year, that criteria of the Controlled Substances Act is no longer met. And honestly, if we were thinking about how the U.S. Attorney General would apply cannabis policy. If the Attorney General were applying the Controlled Substances Act as written, cannabis would be rescheduled. It's a complicated issue, of course, so it's not one that he or any other Attorney General would lightly change because of the history of this product, but nonetheless, we might anticipate movement in this in the future. As a consequence of the evidence, a number of states, 29 states as of now, and the District of Columbia, have passed laws that recognize the value of whole plant cannabis. And an additional group of states, Georgia being one, have passed laws that permit low THC, high CBD oil extracts. The graph that you see on the upper right of this slide, the blue bars represent the states that have turned on whole plant cannabis. Georgia is one of the, appropriately enough, one of the red bars that you see towards the right of that have more recently turned on the low THC, high CBD oil extracts. And so, we've got regional variation to be sure, but states like Arkansas, like Florida have now whole plant cannabis. Louisiana is in the process of implementing a law. So it's no longer just a coastal northeastern phenomenon. This is widely accepted around the country. And one of the most important developments from a clinical side has happened in January of this year when the National Academies of Sciences, Engineering, and Medicine published a definitive report that they conducted of over 10,000 English language peer-reviewed journal articles where they evaluated whether or not there was any evidence for the application of cannabis to clinical conditions. And I will tell you that this is an extremely conservative organization. I don't mean conservative politically. I mean conservative in that they're unwilling to make definitive statements unless they feel there is absolutely compelling evidence. And so they were actually were able to say that there's conclusive evidence that that cannabis is effective for chronic pain in adults, for nausea related to chemotherapy and other sources of nausea, and for spasticity. Conclusive evidence is a very high, large randomized controlled trial standard. For most of us, we would also take what they consider moderate evidence as quite compelling. In the social sciences, we couldn't ever do any better than moderate evidence from their perspective. And what they find is that cannabis is effective for sleep, for various sorts of pain, and for managing spasticity as well.
Dr. Bradford, let me just, for the members of the committee, just a reminder that we had considered pain in last year's legislation. It was removed for various reasons, but it is interesting and compelling that at least this report is saying that for chronic pain, there is conclusive evidence that it does provide some benefit. So.
Yes.
Yep. What number are you, Representative Jones? Okay.
Thank you. Professor, on the effects, does it delineate, is it low THC, full THC? I mean, what's the difference? We have such a variation.
Sure, and it is a very long literature. Like as I said, there were 10,000 articles that slightly more that they reviewed, and I would actually encourage the committee to download the report. It's freely available, the PDF of the whole. It's 400 pages, but it's actually nice bullet summaries at the beginning of each chapter. And so the conclusive and the moderate evidence applies across the board for extracts, for pharmaceutical THC derivatives. There are several pharmaceutical products that are based on cannabis, and indeed for botanical cannabis. The evidence will vary slightly depending upon the condition that they're looking at and the studies that have been done. But as I recall, all three delivery mechanisms were included in some of the conclusive and moderate effects that they saw.
So, just follow up, Mr. My impression would, just from what I've read, would be it would depend on the condition, and like pain might need something different than seizure disorder.
I think there's no question.
Respond better.
Yeah, I think there's no question that that there's a lot to be learned still. Cannabis, as you know, is an extremely complex plant with many different cannabinoids and terpenoids and a whole host of active ingredients. and it's unclear sometimes whether it's the CBD or the THC or any of the dozens of other plants, but or compounds. But so I do think that that the strains and the hybrids that would be have been tested do vary based upon what condition the investigators are trying to study. I will say that there is a growing scientific data set that is doing very detailed chemical analyses of each of these hybrids to try to classify the amounts of each of these compounds that are in there, so that they can begin to understand the best combination for the different conditions. Yeah. But chronic pain, I will say, is something that that is very widely seen as something that benefits cannabis can benefit. Canada has recently approved cannabis, whole plant cannabis, and chronic pain is one of their primary reasons for doing it. Let me just say that there's not a lot of evidence that that cannabis can treat other conditions. Not that it doesn't treat it; it's just there have not been enough studies done to be definitive about that. Right. So, so in any event, I should say the law is changing. I mean, the evidence is changing. Laws across the country are changing. I think that it's probably the consensus of people who study adoption of these laws that we're likely to see most states break towards an approved version of cannabis. Nearly all states have some form of it now. But in terms of whether or not every state moves to whole plant cannabis is an open question, though it seems likely. And much of it is going to depend ultimately upon how the, resolving the conflict between federal law under the Controlled Substances Act and state law. I will tell you, in the latest public opinion polls Quinnipiac conducted this summer, remarkably, 90% of Americans approve access for patients to medical cannabis. 93% of Americans on average, 96% Democrats, 90% Republicans, approaching 90% people age 65 and over. So across the board, as far as the popular opinion is considered, this is a settled matter, a remarkably settled matter given the conflict with federal law. I actually don't know of another area of policy where public opinion is so settled on it and policy still differs. Clinically, this is a settled matter. There are clinical benefits. We just need the policies to catch up. Policies process takes some time, though, so we'll get there. So what do we know about the benefits? Let me go into now some of the research that academics have done about this. And I'm going to briefly say that if we think about approving medical marijuana laws, medical cannabis laws, and I'll use those terms interchangeably, there's evidence that medical cannabis laws are associated with lower traffic fatalities. There's a reason to actually expect that would be the case. Primarily because there are no bars associated with cannabis consumption, and there are bars associated with alcohol consumption. The two seem to be substitutes of one another. Cannabis can't kill you; alcohol can. So the fact that we're seeing fewer alcohol-related fatalities is to be expected. We do seem to see some benefits associated with suicides actually completed and suicide attempts. We don't have any evidence that this is driving underage drinking. We don't see a large effect on the sort of perceptions of the riskiness of regular cannabis use for recreational purposes. Criminal offenses aren't changing really, and there is growing evidence, and I'm going to talk to you in a few minutes about some that we've generated that suggests that we actually do see significant diversion from opiate use, and as a consequence, significant benefits in terms of opiate mortality. So there are spillover benefits that are not even non-trivial, but actually quite substantial here. As far as the negative externalities, negative spillovers go, it seems that medical cannabis, there is some worry about diversion. It seems, I will tell you, that since the 2012 study, there's been less evidence of that as states have gotten their distribution systems more controlled, and also slightly higher increase of arrests for men having cannabis without a medical card, right? So there is a little evidence that we have to be careful, as with any substance that we're trying to manage. Policy's got to be devised appropriately. All right, so what are we studying? So we're actually, my daughter Ashley and I and our two colleagues from the University of Georgia are asking how is it that when states turn on whole plant cannabis laws and allow people access for medical purposes, how do we see people reacting in terms of their medical uses? Are they reacting to cannabis as if it's medicine? And if they are, let's look for evidence of it. And one way that we would see the evidence is that we would see that when this new therapeutic option becomes available, it substitutes for existing therapeutic options. That is, if cannabis is in fact an effective therapy for pain, what you should see when patients get access to it, we can't actually observe the cannabis use. I'll say there's no data that lets us use that. But what we should see, of course, is that the utilization of pain medications approved by the FDA goes down as people substitute towards cannabis. And so we're asking that question. We want to be really careful about asking the question because we want to ask questions about conditions where cannabis might be effective. We don't want to ask about the flu. Nobody's going to be treating the flu with cannabis, but they might treat anxiety, they might treat depression, sleep disorders, pain management, a whole host of things. So we actually have the first study that came out on this subject. We were actually surprised when we sat down to do another study that this one hadn't been done because we needed the results of this, my daughter and I. So we said, I can't believe anybody hasn't done that. Nobody had. So we published a study a bit more than a year ago, looking at Medicare Part D. This study came out in Health Affairs and received quite a bit of national attention, I will say. I was actually pretty surprised at how much real people wanted to know about this academic publication. I'm going to go over the results of an extended version that we've just completed that's actually about to come out in another peer-reviewed journal that takes the data up to 2015 and also emphasizes an important thing that I hope you guys consider as you're contemplating policy for Georgia, and that is what's the distribution mechanism for the actual product, right? So in the results I'm going to show you, we're asking, did implementing an effective medical cannabis law change the prescribing patterns in Medicare? So we're looking at older people primarily here. And does the type of law matter? That is, if you allow home cultivation, what result do you get? If you actually establish dispensaries to distribute this product in a controlled way with advice from the dispensary owners, what kind of result do you get? We're going to look at it in Medicare and Medicaid. The first results are from Medicare. Let me just quickly say that we're gonna only look at laws when they're in place. That is, a law may be signed into a bill may be signed into law, and it may take a year before it technically goes into effect. And then if it's a dispensary-based law, it may take a year or two beyond that before the dispensary is open. We're only looking at laws being effective when patients actually can get access legally to the product. Actually, I don't know how I would treat Georgia right now if we were doing a study on low THC oil, because it is we're in an odd limbo period right now. So we're not studying that happily. I haven't had made that call yet. So we're going to study conditions, as I said, that there's evidence that cannabis could be effective. Evidence from the clinical evidence that I mentioned earlier, and from state laws that say this is what we'll approve it for. So we got data on all Medicare Part D prescribing. It's about 130 million physician drug observations. So we have the census. All drugs prescribed in Medicare Part D are the ones that we studied. So this is a good sample. Couldn't get any better. It's not really a sample in some degree. Now these numbers are small. I can't see them from here. I don't think you can. Let me just broadly say to you, when we're looking at the number of daily doses that physicians prescribe, what happens is substantial reductions in prescribing across the board, with the exception of glaucoma, which is weird, and afterwards, if you're interested in glaucoma, I'll tell you about that one. But significant reductions in pain and across the board. And I want to draw your attention to pain. If we don't differentiate between the kind of cannabis law, we see about 1,200 doses per doctor per year going down when patients have access to pain. A large portion of those are opiates. I'm going to come back to that in a minute. But when we control for dispensary versus home cultivation, we really see the big effects are coming in at dispensary-based laws. When dispensaries are available, about 2,400 fewer daily doses per doctor, right? And there's 350,000 doctors in the United States, per doctor per year, just for Medicare Part D. Now, what that means is that, in terms of just converting this into dollars, when we look at sort of controlling for dispensary versus home cultivation, for the laws that were actually in place, in 2015, Medicare spent about $263 million less on all those prescription drugs because of what is an apparent substitution away from prescription drugs to cannabis use. And indeed, if we ask what would have happened if all states had turned on this law and made dispensary-based cannabis available to their patients, Medicare, just Medicare Part D, would have saved about $1.7 billion. So this is significant, and it's about 1.5% of Medicare Part D spending. You know, Medicare, you can get to billions pretty fast, even when it's not gigantic percentages, right? We have recently taken a look specifically, same approach, but specifically at opioids. And I will tell you that one of the results I'm going to show you here were done at the state level, so all the numbers reflect millions of daily doses, right? And so what we find is that, just cutting to the ultimate chase here on the second column, when states turn on marijuana dispensaries, there are about 3.7 million fewer opiate doses in the average state as a consequence of, just in Medicare, of turning on access. That's about 14%. 14.5% of the opiates are now not consumed. Again, remember, the therapeutic index for opiates, that is, if you're thinking about hydrocodone or oxycodone, the ratio of the fatal dose divided by the median dose is about 5 or 6. That is, if you take 5 times the therapeutic dose for one of these drugs, oxycodone, you'll die from respiratory suppression. Cannabis, it can't be measured because cannabis cannot kill you. And there's, in fact, as the National Academy of Sciences points out, never been a single documented case of a fatality from cannabis. So we're shifting people 3.7 million doses of a drug that's very valuable, can be very effective and life-saving for some people, but deadly for other people, right? So shifting it from one to a drug that can't be deadly. We actually see, when we break it down by drug, most of the effect coming through hydrocodone, fentanyl, which is a drug that I hope is on your radar screens if you're thinking about opiate policy in the United States. Morphine reductions in this sort of other drug category. Let me just quickly say that we redid the analyses for Medicaid using exactly the same procedure. We took data on all the fee-for-service Medicaid prescriptions at the state quarter level, studied the same drugs, and we found results that were the same, identical. I'm not going to show you the point estimates now, but larger than in the Medicare population. Again, this is hard to read, but if we look at the laws, the actual laws as written, in 2014, states saw, we believe, about $223 million lower state spending for Medicaid, and the federal government saw about $252 million lower spending on the federal share of Medicaid. If all states were to have turned on medical cannabis laws, we think that between the two of them, there'd be about there would have been about $1 billion in savings just for fee-for-service Medicaid. And as you know, fee-for-service Medicaid is only about 26% of all Medicaid. Here in Georgia, it's a little bit higher. I think it's about 30% for us. So if you extrapolate these to the entire Medicaid, not just fee-for-service, but also managed care, assume, this is a big assumption, assume that the Departments of Health claw back the unused money from the spending to the capitation payments. If you make that assumption, you know, Georgia could have saved about $36 million from the Medicaid program in 2014.
Okay, I almost want to hit that, particularly to you members, particularly Ms. Dempsey, Representative Dempsey, who's on the Budget Committee, and Representative Jones, you know, who's key in the budget. I mean, so this is clear data that is showing that if there were a dispensary-based operation in Georgia, that just for Medicaid, we would have saved north of $30 million.
Actually, if I could, this study replicated our original health affairs study. We didn't make the distinction between dispensaries and home cultivation.
Okay.
I will tell you that given all the other work we've done, the results would be significantly bigger, maybe 30 or 40% bigger, if we had taken dispensaries into account.
Wow. So, I mean, so that is a huge number. I mean, we're talking about, you know, so maybe $50 to $60 million
In state money.
In state money that we would save if there was a dispensary program in place from reduction in opioid usage. Is that correct? Is that
That's right.
am I saying that right?
Across the board for,
Right.
for all of them.
Right.
You know, we've not tried to do this for you, but if you want it, we're actually happy to carve out a specific Georgia set and give you estimates for what would happen in Georgia under various scenarios.
But why don't you consider the request being made?
Okay, all right. So we'll send you a short report on that.
Yeah. Let's see. Is that Representative Beskin? Yep.
Thank you, Mr. Chairman. Thank you, Dr. Professor. Do third-party payers or Medicare or Medicaid reimburse for this, for the marijuana, the CBD, or the whole plant marijuana? And is there a move afoot? If the answer to that is no, I really don't know the answer. Is there a move afoot to get coverage for this if, in fact, it is replacing a current prescription?
It's an excellent question. Yes, oftentimes when we talk about cannabis policy around the country, people gloss over a couple of things. One, people often say, oh, the physician can prescribe cannabis. Of course, physicians cannot prescribe cannabis. It's a Schedule I drug. And in answer to your question, almost entirely, cannabis is not reimbursed by Medicare, Medicaid, or third-party payers. I can't foresee in the world that as far as I can see, that Medicare or Medicaid would do so. I will tell you that New Mexico is currently on the front lines of that question, because New Mexico has in fact passed law, or the New Mexico state courts, I honestly can't remember which it was, have interpreted the law to require third-party payers to pay for it or reimburse for cannabis for medical cannabis patients with an approved card. That's actually currently being worked through the courts as to whether or not they can do that or not. So I don't think it's settled, but they're the only ones who tried it.
That's a good question, yeah.
So right now, this would just be complete savings. It is, however, of course, a shift of burden of expenditures from Medicaid to the patients themselves. So that's something to bear in mind. All right, let me just hit one final thing, and I may actually make my 30-minute limit. And just in terms of what's going on with accidental drug deaths. So Ashley and Grace and Amanda and I have taken data from the national death certificate data. So we've gotten data on all deaths in the United States and looked at the ones at the causes of death. As you well know, these two lines here show you the trends in opiate-related mortality. The top blue line is the one that's associated with prescription products like oxycodone, fentanyl, hydrocodone. I will say fentanyl in this world is almost entirely illicit fentanyl. It's fentanyl that's sold through pharmacies is not easily diverted to abuse. It mostly is a patch or a grape flavor lollipop. But there's illicit fentanyl that has made it, unfortunately, into the United States. And so you'll see that the tick up in pharmaceutical-related deaths at the end is almost exclusively a fentanyl phenomenon. And the bottom line is heroin-related deaths, which have begun to really increase substantially since 2010. Again, heroin and fentanyl are being co-used, unfortunately. So Georgia, of course, has not escaped this problem. This is the death rate in Georgia counties in 2000, and I'm just going to let this run as time moves forward. You see what's happened as we progress through the 2000s. I think it's going to end in 2014. And I will tell you the map is darker in 2015 and is likely to be substantially darker in 2016. The nationally, the death rate is accelerating again from opiates, primarily, again, driven by fentanyl. So we need to do whatever we can to divert people away from opiates, right? So our earlier studies that I talked to you about suggest, in fact, people can be diverted away from opiates with access to cannabis. And if you divert people from opiates, you divert them from a chance of misuse, abuse, and ultimately mortality. But the ultimate question is, what's the impact on mortality? So we studied this question, looking at data from 2000 to 2015, turning on dispensary-based and home cultivation-based cannabis laws, as I've mentioned before. And I think this is my the slide I'm going to show you here. Just presenting evidence from the last few years of our data. I'll just jump to the last year. We estimate that in reality that about 280 lives were saved because of the medical cannabis laws as they had been implemented. Again, 29 states had them, but not 29 states had them implemented. So 81 lives have been saved in 2015. This is from a base of about 20,000 non-heroin related opiate deaths, right? If all states had turned on a dispensary-based program in 2015, we estimate that about 2,300 lives would have been saved. So right at 10% of the opiate mortality, non-heroin related opiate mortality could have been avoided in 2015 if all states had active cannabis dispensary systems in place. All right, so just to sort of conclude, we have 29 states. More than 2/3 of the U.S. population live with some form of whole plant access at the moment. The National Academies of Sciences, Engineering, and Medicine, the authoritative voice on these matters in the world, frankly, has concluded that there is conclusive evidence that cannabis has some medically effective uses. When you implement medical cannabis laws, we see that there are reductions in prescription drug use. Turns out to save money for the governments and the other, presumably other third-party providers as well. And you can actually save lives. And so I sort of want to close with the statement that I did when I was before your group last time, which is, if you appropriately design medical cannabis laws, you can save both lives and money. So I thank you for the chance to talk to you, and I'm happy to answer any further questions you have.
Thanks, Dr. Bradford. And we'll see if some of our members have questions. Let me ask a couple of questions and just make a statement. I know Governor Deal has made it a priority. I believe Speaker has. I think Lieutenant Governor has. I know at the federal level, it's been declared that opioid usage is an epidemic, and there's a real commitment at the state level to deal with this issue. To this committee, and I hope that we'll share it with the rest of our colleagues, that there is clear, if we are really, really serious about dealing with the opioid epidemic in our state, this data, and I'm going to ask you a question about it in a minute, about other data, provides clear, compelling evidence that if we were to implement a dispensary-type program in our state for medical cannabis, that it would reduce opioid usage, abuse, and deaths. It's clear data, not just a pie-in-the-sky hope. And so I hope that we'll share that message with our colleagues that that this is something that if we really are serious about dealing with the opioid epidemic, here is a potential solution to deal with that. And the second question I got is the question I've got, Dr. Bradford. This is not just your study. Am I not correct? Because I think I've seen that there are other studies now across the country, kind of piggybacking off of the work that you did. Yeah. Quite frankly, other independent, peer-reviewed research data that is showing the same conclusions. Is that correct?
That's correct. In fact, there's one published by, I can't remember his first name, Martin, I think, Bachhuber, and colleagues in the New England Journal of Medicine, using a state-level analysis that shows substantial lives saved when medical cannabis laws are put in place. Right. So I think our results in terms of medical spending is being replicated now, and others have picked that up and have shown similar effects. And we and Bachhuber and several others across the country are showing significant reductions in mortality associated with allowing access to cannabis, mostly mortality from opiate reductions.
Okay. I know we have some questions. Representative Jones.
Thank you, Mr. Chairman. And I have to plead more ignorance than the rest of the committee since I'm not officially on the committee, but you referred several times to whole plant versus dispensary, and I was vaguely aware that University of Mississippi is the only place that, I guess it's a federal...
For studies, for clinical studies, that's right.
How many states have have dispensaries, and where do they get the product?
And where do they get the
product?
Okay, great question. I'm going to work a little bit I'm working completely off my memory, so these are going to be in the ballpark of right. So since 2007, every state that has approved medical cannabis, that is, I'm setting aside the extracts like Georgia has, but every state since 2007 that has approved medical cannabis has approved it with dispensary-based distributions. So of the 29 states with medical cannabis laws either in effect or being put in place, I think nearly all of them now have dispensary-based systems.
And Dr. Bradford, let me just, and when you say dispensary-based, meaning they are growing the product in their state, they are processing it into whatever extract, and then providing it in that final form to the citizens from growing it in their state.
Yes,
Is
and
that not correct?
so a dispensary it's like a pharmacy where you go but you're buying cannabis instead of prescription drugs, right? The dispensaries, and in most states, this means that there are edible versions of it. There are leaf or bud versions of it. There are oil extract versions of it. And so in Colorado or Washington or Oregon or Vermont or Maine, you would go in and you'd see all forms of cannabis available in a brick and mortar dispensary, just like a pharmacy. And that's the reason that the dispensaries are so effective for opiates. If you're a physician and your patient's got back pain, if you say, oh, you can go down the street to the pharmacy and get an opiate, or you can go down to the street to the dispensary and get cannabis, then cannabis has a fighting chance. If it's, oh, you have to go home and grow it yourself, wait 2 months, do lots of work, cannabis doesn't have much of a chance, right? But in terms of where is the cannabis coming from, these are very tightly regulated production markets within each state. So you can't transport this across state lines. So the cannabis that's sold in Maine is grown in Maine. And in nearly all states that I'm aware of, this is tightly controlled to the sense of every seedling has got to have a barcode attached to it. The barcode is tracked with a central database so that there's sort of from seed to shelf logistical control of the product. And states have been implementing this, and we, I guess, benefit from the fact that Colorado, Washington, Oregon, and others wanted to go first. And so we see now good models for how to make it happen. And I will also say, although this is not necessarily, I don't know if this is a good reason or not, but these states are also reaping substantial tax revenues from the sale of clinical cannabis and recreational cannabis. We're going to probably, when the estimates come in from this year, we will have exceeded $1 billion nationwide for state tax revenues associated with cannabis sales. So these are tightly controlled logistic systems, and there should be no leakage out of states.
Further question. So I realize there's a number of states that have also legalized recreational marijuana.
Right.
8 or 10.
I think 9, but that's around. Yeah.
Are they different storefronts, or just do you buy the medicinal and the recreational in the same place?
It's a great question, and the states, I think, were a little caught by surprise in terms of how this worked out in practice, because as I remember it, in Colorado, Washington, Oregon, the three that I'm familiar with that do both, they were in fact different stores. They in fact had different tax rates attached to them, and so they're still in the process of figuring that out. Yeah. It's caused some dislocation when you're a medical cannabis patient and your cannabis has a higher tax than the recreational cannabis, but you're trying to maintain sort of the medical side of things, and so they're figuring it out.
Let's see, Representative Gravely.
And just thank you, Doctor, for your presentation.
Sure.
Matter of fact, I used some of the information you gave us back during the session for the Cobb legal professionals on an opioid medical cannabis program, and it was very beneficial. And I think they were very impressed to see the amount of data that was compiled. So thank you very much.
For sure. Thanks.
Also, along on the opioids, I believe Americans for Safe Access has statistics that say 91 people a day are dying from an opioid overdose of some kind.
It's 2 747s a week crashing every week. Yeah, and it's accelerating. This time next year, it's going to be 3 747s a week crashing. Fentanyl. I cannot emphasize to you enough the seriousness of fentanyl. And I know people are naturally and reasonably, and certainly those of us who are of at least my age, raised on reefer madness films in school, are sometimes hesitant about cannabis. But we should be terrified of fentanyl. And anything that can divert people away from that, we have to take advantage of. Fentanyl is the most deadly thing problem we face right now.
Further, Mr. Chairman. I would 100% agree. I have a constituent, a family in my district right now, whose son, unfortunately, was addicted to opioids and got a hold of something that was laced with fentanyl, and then has tragically died from it. A young man in my district. But to kind of further address Madam Pro Tem, the dispensaries look different among the varying states, and they're allowed to dispense whatever the state has legislated that they. So some may just have oils, lotions, and vapes, while others have an array of different forms and styles or whatnot. Correct?
That's correct. As I recall off the top of my head, New York has restricted use from smoking. So you're not allowed to smoke, but they do have edibles, oils, and vaping, I guess, doesn't count as smoking. So New York State does have that restriction. Most states don't have it, but New York does.
And depending on the state, the only one that I've been to, and I was very impressed with Minnesota. We went into a facility there that looked like a small medical clinic. It was very nice. There was a state board certified pharmacist that was there at all times. So I think it varies, and depending on how Georgia would want to set theirs up, we could do something totally different. We could look at how the other states are doing it, choose our own, what is the best path for Georgia, correct?
Absolutely. I think that one of the great things about a federal system is that states can tailor the policies to themselves, and you absolutely will see a spectrum of rules and availability. But I will say that my impression is like yours, that when you go nearly everywhere into a medical cannabis dispensary, it is a very professional organization. I mean, they very clearly want to not have scandals, maintain the professionalism that you come to associate with the medical community, because they know that they're kind of on the vanguard of a policy change, and mistakes are going to be amplified. So we can make whatever policy we think fits for Georgia. I hope that will ultimately mean our residents get access to the option to use cannabis if it works for them, because there's evidence that it works for some people amazingly well, and it has very few side effects, not zero. I don't think anybody here is saying, okay, well, let's just free for all put cannabis lollipops on every corner. It has to be. You have to be careful about what you do, but there's no reason to be afraid of moving forward carefully.
Absolutely. Thank you.
Mr. Bradford, we continue to hear, we do testimony that it's a violation of federal law. It's a break in federal law, and so that's kind of the pushback that this committee and we have heard as legislators from law enforcement, from DA, that that's really the stumbling block to us moving forward. Now that there are dispensary type models in 29 states and low THC oil possession only laws like ours in 14 other states, what would you reckon? Is that a real potential that the federal government would come in and shut down an operation that we put in place with what's going on throughout the country right now? Can you just opine on that?
Sure. I think that is one of the great unknown. Well, that's not really unknown. This is one of the things that everybody is struggling with, right? Is that the current implementation of the Controlled Substances Act at the federal level makes cannabis illegal, no matter what the states say from a federal perspective. As I said before, the actual language of the Controlled Substances Act would not have cannabis be illegal, but it's up to the Attorney General to change it. Now, the Attorney General Sessions has not seemed eager to do so. Attorney General Holder was not eager to do so. So this is not a partisan issue. I think there's just uncertainty at the federal level, and the fact that this is in some sense heavily influenced by the DEA, where 25% of their budget is associated with cannabis interdiction. Right. But there is the Rohrbach, I believe if I remember correctly, an amendment that prohibits the federal government from spending any money to pursue cannabis use or production in any state that's consistent with that state's laws. As I said, public opinion is absolutely settled on this issue. I cannot think of another unsettled question where 93% of Americans believe the law should be a particular way, and it's still not. The scientific evidence is snowballing with regard to the benefits, particularly for areas like pain, for nausea, for spasticity. I cannot see a rational world where the federal government chooses to pick a fight with the states over something that is wildly popular amongst Democrats and Republicans, and which pretty much every medical group would now say should be done. I mean, they might. I guess you can't rule it out, but it would be pretty irrational, and I think the federal government has bigger problems on its hands.
And I would assume that, am I correct, that the risk would not be to the states that have implemented the program, but it would be to the private industry that, let's just say the federal government said, okay, we're going to shut down everybody. It wouldn't put our states at risk. It would put the private industry who is invested in a dispensary.
That's correct, and the patients. Although I would say, and this is, I guess, a little bit of in the weeds as to policy process, but I in some way wish that that Attorney General Sessions would act on his stated goals and actually try to close down dispensaries in one of these states. Because what would then happen is the states, our work and other people's work showing, for example, that state Medicaid dollars would then go up as a consequence. States would then have standing in court to sue the Attorney General, asking the courts to order him to implement the Controlled Substances Act as written. And I cannot see a world in which the courts would find for the Attorney General in that case. Cannabis would be rescheduled, and it would be taken to Schedule 3 probably, or taken off the schedule potentially. So honestly, I wish that it would go to a head so we could get it to the courts and have it decided.
I think the interesting side note, there actually is a federal lawsuit that has been initiated, and I think one of the folks in our gallery here today is one of the plaintiffs. Am I correct, Mr. Cott? Yeah. Actually, that has been filed on behalf of six individuals across the country. So we may see that. Representative Stovall had a question.
So what is any of the pushback from the pharmaceutical companies?
Pharmaceutical companies are not particularly pleased with the prospect of cannabis. For example, last year, in the 2016 cycle, there were 12 states with cannabis liberalization policies on the books, and what I think was a terrible case of bad optics. The primary manufacturer of fentanyl contributed $500,000 to the anti-medical cannabis initiative in New Mexico. Arizona. So, I mean, the pharmaceutical company, if you take our work as given, we would suggest taking Medicaid and Medicare together, that if every state turned on dispensary-based cannabis laws, there would be about a $3 to $5 billion reduction in pharmaceutical spending just from Medicare and Medicaid nationally. And that's a lot of money that's not going into the bottom line of the pharmaceutical industry. So they're obviously uncertain about this. Now, it's true that if it were liberalized, they could then develop products based on cannabis. That's a little difficult if their products actually aren't much better than whole plant cannabis, because it's always be probably cheaper to go get whole plant cannabis. So I don't know that they're all in against it, but they're definitely hesitant about it if you take a look at their political contributions.
Okay. Dr. Bradford, thank you so much. I appreciate your presentation, and we'll follow up and kind of get your whole presentation to all the members as well too. So that's very helpful, and I'm hoping we might get you back while we're in session as well too. So
sure, I'd love to. I appreciate you guys devoting the energy to this, and I appreciate the chance to talk to you today.
Right, thanks, Dr. Bradford.
Thanks.
Yeah. Just to the members of the committee, just a reminder, there is a bill, HB 645, that was filed on the last day of the session that would set up or grant licenses, grant 2 licenses to be able to grow, process, and distribute medical cannabis, oil only, as it's written and defined in Georgia law, that was introduced on the last day of last session that hopefully we'll get some discussion during the next session. So this dispensary issue we can resolve. We do have legislation out there that could potentially address that. So. Okay, our last presenter today, Mr. Jack Spruill. Yeah, you'll come on up, and who's with the Department of Agriculture, and we've asked Commissioner Black to come. He could not, and so, yeah, and Mr. Sproul is here just to talk about, very briefly about hemp in our state. There's a wave across the country of laws being passed that allows hemp production, which is technically and contains some components of the medical cannabis plant, and has also been seen to be effective for the very low THC oil production from hemp. So I thought it might be prudent to see, as well as other industrial uses as well too. So I thought we might just at least get the position of the Agriculture Department on this issue while we're meeting today. So, Ms.
I happen
Sproul.
to know Commissioner Black's 72-hour schedule. He would much rather be here.
Okay.
He is a very busy person, but thank you for having me.
We're glad to have you
Chairman.
here.
Glad to be here. I don't want to be anything negative because all we've heard today is positive. But I must tell you, the opioid, I have a close relationship with my sister's family. I know of that danger. I know of those problems. So please don't take anything from a departmental perspective as a personal negative for myself or Commissioner Black. That's not the case here. We're trying to be very diligent in what we say to make sure that we see areas that we have critical knowledge needs, but not that we are critically negative. So please don't construe that as being the same. I think the 2014 Farm Bill, as signed into law, did give a path towards states to do research through departments of agriculture and through land-grant universities or major institutes of learning to research and do things on industrial hemp. And as you so adequately said, low THC oil is part of that derivative thereof, plus the industrial usages. But I want to say, and I want to emphasize that word gave a path. It did not give a road. It did not give a road map. It certainly did not pave an interstate highway. And if you look at the way those states have attempted to implement and use this, you will see lots of variation in how they've done it. There is no clear path. You are blazing a trail, so to speak, when you do that. Not that blazing trails is not sometimes fun, but we like to have others do it. You get a lot of arrows if you're out in front of the pack usually. It's been said 15 times, and I think the Department of Agriculture's position is there's a lot of federal questions to be answered. There's a lot of federal concerns that should and we would hope would be addressed. Because if we look, and this may be a poor analogy at this point in the game, if we look at it from an agronomic situation and we look at the situation we have in Georgia today, I have attended all of the rural development caucuses that I could, meetings, chaired by Representative England, Representative Powell. I've been a presenter at them. Folks, rural Georgia would love an agronomic crop that could bring some vitality to rural Georgia. If that be industrial hemp, if that be anything, we would look at it as a blessing. With cotton prices and 1.6 million acres of cotton as there are, rural Georgia being agriculture could use anything that was an agronomically viable crop to come into this state that would help that rural economy. But the analogy comes back if we look at the fish industry, for example. Georgia's probably producing less than 1% of the fish consumed in this state. But we certainly have no federal barriers to getting all the fish we want. That would be an easy solution if we could indeed not have to grow and process within the state, if it was federally permissible, that it didn't have to be quarantined to this state. Department of Agriculture has no guns and no badges. We deal effectively with administrative procedures. If we have a grain warehouse which is undersecured, we file administrative procedures, and we're very adequate at getting them in and making sure they're bonded. We can't tell you, and as we so adequately said, the young lady who presented first, when the 17-year-old representative self is a doctor, we know that there are areas, we know there's got to be due diligence, we know there are barriers to what we can and can't do. Now, we want to cooperate 100%, the state legislature and the governor. What we are told to do, we will do our best to do. We're not, again, being negative. We're saying there are some critical areas we would like very significant guidance on because we're not DEA, we're not law enforcement. We are an agronomic engine that looks after this state. We're not even presenting to you, and I would hesitate to say this, that You know, could we tool up? Could we ramp up? Could we do more if we had resources? Because we talked about some $36 million in savings. If we look at it from a personal perspective within the Department of Agriculture today, and this is not meant to be a complaint, it's the cards we're dealt. When we've got an 18-year employee with a master's degree who we're paying $41,000 a year as a supervisor, we probably, if we had monies generated at the Department of Agriculture, would rather use them for other purposes, not being negative toward this purpose, but being honest with you on where our needs are. Again, I don't want this to sound negative. We look at a lot of federal issues with it. We look at the lack of enforcement we have on a product today that federally still falls outside of being illegal. We look at the problems that we have with no registered usage, pesticides, herbicides, and whatever, except in a university proper. And we don't know how we could administer it. We stand again ready to be assist as we are legislatively demanded, our agency, and with blessings and the governor's seal of approval, we will do. We are not being negative. We've got a lot of critical questions we don't have answers to at this point.
Okay.
From an agricultural perspective.
Okay. Understand that position, and so okay. Any questions from Mr. Spruill? Are you not getting a request from farmers for?
Yes.
All right. Okay.
We are getting requests from farmers. When can we grow industrial hemp?
Yeah. Okay.
When are we going to be available legally to grow industrial hemp?
So there does appear to be some demand, at least from the farming community.
There is some demand, and you know, whether it's looking for the magic new crop that's going to make them financially whole. I mean, we have a tremendous fiber industry in cotton and timber in this state already. We've got all of these things. I guess my question is, let's go back to the fish example for just a second, and let's look at land-grant universities. Where we invest our time, where we invest our talent, where we invest our treasures, is there always going to be a return on that? We can look at some things farmers have tried in the past where there wasn't. Mm-hmm. And I think that probably as too many people look at industrial hemp today as the new product that's going to take them away from the low prices of cotton and some of those other things they're seeing.
Yeah. Okay.
I don't know that it's truthfully any ill motive in it. They're looking for something they can profit from.
Okay.
But we are getting those questions.
Representative Graves got a question for you. Can you mind taking a question?
Yes, sir.
Just to, do we have any schematic or anything like that of what some of the international markets are for industrial? I mean, I know there could probably, I had a constituent that was, before the laws were passed here, was taking industrial hemp oil for their child. Wasn't working as good as the new product, but it was something that they were working on. Other than the oil, whether it be product or rope, or is there a market where some of these other states are farmers who have taken or tried to carve a path out? They're seeing goods being sold on this market, or there's a demand in this country or even domestically for whatever the hemp products may be.
Long article published, and it came from the United Kingdom. And it said we are looking today at the research and the application. We list some 26,000 products available from industrial hemp, but the problem is they haven't been produced in so long. I'm sure they can be produced. Can they be produced economically and with a return? I don't know that answer. The article from the United Kingdom that I was reading was trying to quote the problems that they had with seed, with variety, with soil tillage, with yield, with agronomic practices, and what those yields were expected and a return on it. The only return they could actually produce today, and it's because of interest, was on seed production. They said that was really the only place they saw, and their limited ability to look into it was seed production from a pent-up demand for people wanting to grow it. Then they got into the realm of what the problems are in harvest and what the problems are in further processing it, and they said they really have no benchmarks because there's not enough of it out there to really get a definitive answer.
One more. The climates of these different states, is Georgia conducive? I mean, is our climate, is our soil, are we conducive to, if this were to pass, and let's say there was legislation and you had the tools, or the department had the tools to implement some type of an infrastructure, is Georgia's climate and soil levels? Are
It would be a personal assumption that it is based
Okay.
on what we can grow, because we are real blessed with a beautiful climate for growing almost anything. And I guess then we look at what this industrial hemp legislation says, and they talk about a THC level of less than 0.3%, except West Virginia, which is 1%. And then this United Kingdom article, this article from Great Britain, went into the question of, is that on different soil types? Is that based on irrigation rates? Is that based on harvest date? Is that based on whole plant harvest? Is it based on only the leaf harvest? So I think there's a lot of, again, critical questions we don't know the answers to.
Okay, thank you.
So if I can summarize, and I don't want to put words in your mouth, but the department's position would be they're cautious at this point.
Very cautious. Yes.
But if the legislature, in its wisdom, decided to move down this path of allowing hemp production, that you guys would figure out a way to make it work. Is that a
With
fair?
help.
If that a fair assumption?
With
Yeah.
help.
Okay. Thank
Yes.
you, Mr. Brewer. Thank you for being here.
Thank you.
To the members of the committee, thank you for your patience and diligence in being here. Appreciate it. This issue is not going to go away. It's going to be one we'll continue to probably have discussion about, because it's clear that our citizens want us to do that. So, Representative Grable, have you got something you wanted to say? Yep.
Thank you, Mr. Chairman, for indulging me. Just to make sure that the members of the committee know, and members of our audience today, I had a friend, I think, that had been at many of these meetings I sent from the beginning, a Douglas County resident who fought day in and day out for transparency, and we didn't always agree on everything, but he was always very kind to me, and I had great respect for him. But James Bell passed away back in September of a heart attack suddenly, and I know that he attended and filmed a lot of these meetings, and I just wanted to recognize to this committee that he was a passionate advocate for making sure that citizens in this state had access to medicine.
Thank you for that. And with that, we are adjourned. Thank you.